The most common focal hypervascular mass of the liver is the hemangioma. Here we show a ring-like density in the right lobe of the liver on this selective common hepatic arteriogram that shows what has been called by the Japanese the engagement ring sign, which is almost pathognomonic of a capillary hemangiomas. This second case is a large focal hypervascular mass. Also in the periphery of the mass, we can see a ring-like opacification represents a cavernous hemangioma of the liver. This is a cast corrosion preparation of a hemangioma of the liver. Hemangiomas can be seen in normal livers and occasionally are associated with other abnormalities. And in liver cirrhosis, acquired hemangiomas may be observed if the vessel that dilates are at the level of the capillaries. This is called pileosis hepatica. These hemangiomas of the liver typically show a opaque ring, and later contrast may be seen within the lesion. This is beautifully demonstrated on sequential CT images in scintigraphic examination of the liver, as well as on magnetic resonance studies. It is a delay increase in activity in the center of the lesion, what is typical of the cavernous hemangiomas. Rarely, a hepatoma may have a similar appearance. One of the most hypervascular tumors of the liver is the hepatoma. This is a specimen that shows that in the left lobe of the liver, there is a reddish mass. Note the yellow spots in the surface of the right lobe. This liver has a smooth surface, so we do not suspect, in this case, the presence of cirrhosis of the liver. A cast corrosion preparation of the liver shows the intense arterial hypervascularity at the level of the hepatoma. Note that in this region we do not see blue and we see very little yellow. This is because hepatomas are notorious for obstructing the veins, both the portal and the hepatic veins. The little yellow spots that were seen throughout the right lobe of the liver are the result of intrahepatic metastasis. The hepatoma, when it invades the portal vein, the tumor can spread to other areas of the liver. And that's why we had the yellow nodules, and there is discrete arterial hypervascularity at the level of these nodules. Like with other malignancies, metastases carry the same tendency for vascularity. So if the primary tumor is hypervascular, the metastases are also generally hypervascular. This is a cast corrosion of another patient with a hepatoma. Note the hypervascularity that we see at the expense of the hepatic arteries in the right lobe of the liver. Note that other vessels are missing. Again, an expression of the obstructing tendencies of hepatomas in reference to the portal veins and hepatic vein. Sometimes hepatoma do not exhibit enlargement of supplying arteries, and they do not appear hypervascular on conventional angiographic studies. The top left and right reveal a common hepatic arteriogram with just a discrete blush at the level of the hepatoma. However, the bottom left and right reveal an intense blush, and this occurred following the injection of a vasoconstrictor. The vasoconstrictor, like adrenaline, vasopressin, will narrow the arteries that supply normal liver parenchyma. The arteries of the tumor do not respond like the normal arteries, and therefore flow of contrast and blood is diverted towards the tumor. So the tumor stands out following the injection of a vasoconstrictor. A common hepatic arteriogram of a hepatoma shows to your left increased arterial hypervascularity. Note the enlargement of the common hepatic artery. Also, we note that parent vessels may be smaller than the peripheral arteries. We can see irregular distribution, an anarchic pattern, vessels that have no set course, an intense impregnation of the contrast as seen to your right. These are pathognomonic images of a hypervascular neoplasm and most likely hepatoma. Hepatoma can be seen as a primary tumor or may be associated with other findings due to the fact that it represents a secondary tumor on the basis of cirrhosis of the liver. This is a cast that shows the bifurcation of the portal vein. red was injected into the hepatic artery. And note that we see red not only in the surface of the portal vein, but inside the left branch of the portal vein. This is because the portal vein receives the vasa vasorum from the hepatic artery. And when tumor involves the portal vein and penetrates into the portal vein on cast corrosion preparations and on angiographic studies, we may see the presence of tumor within the portal vein due to the fact that the tumor is fed by the vasa vasorum, which is supplied by the hepatic artery. This is a close-up of the bifurcation of the portal vein showing the dilated vasa vasorum and the neovascularity in the lumen of the portal vein. The portal vein was hollow because it was filled with tumor, and only the wall of the portal vein had the blue plastic. The red penetrates through the wall into the lumen where the tumor invaded the left branch of the portal vein. This is a common hepatic arteriographic examination. To your left, we note a haze at the level of the portal vein. To your right, the portal vein fills readily from the injection of the common hepatic artery. And this is a direct arteriovenous communication. And note that in the lumen of the portal vein, we see a filling defect. So this is virtually pathognomonic of neoplastic involvement of the portal vein, where the vein is communicating with the artery through the vasa vasorum of the wall of the portal vein supplied by the hepatic artery. This is an example of arteriovenous communication that occurs centrally from the common hepatic artery and its primary branches directly to the portal vein. These are two examples of neoplastic involvement of the portal vein. To your left, we note a large filling defect in the portal vein. To your right, complete amputation of the portal vein with marked encasement at its origin. Both were secondary to hepatocellular carcinoma of the liver. These are hepatic venograms on a patient who had a hepatoma. Note that there is a scalloped outline of the right lobe of the liver, filling defects which were due to obliteration of the hepatic veins of this area by the hepatoma. Hepatomas can be unicentric or multicentric, and some unicentric hepatomas, by virtue of invasion of the portal vein, can metastasize to the rest of the liver. Here you can see a localized hepatoma with a hypointense rim in this pulse sequence. This patient had a multicentric hepatocellular carcinoma and a mass in the caudate lobe of the liver, as indicated by the white arrow. There was also involvement of the portal vein, and secondary to obstruction of the portal vein, antegrade periportal collaterals developed, which appear as bright signals in the hilus of the liver. In contrast with hepatomas, cholangiocarcinomas generally do not exhibit the degree of neovascularity observed with hepatomas. Note in the center of the liver the presence of neovascularity. Several vessels appear encased, and this is the classic location for a cholangiocarcinoma, the so-called central cholangiocarcinoma, the Klatskin tumor. Other forms of cholangiocarcinoma that occur within the liver, particularly in the periphery of the liver, tend also to exhibit a minimal neovascularity. Cholangiocarcinomas can occur close to the liver hilus, the so-called Klatskin tumor, or in peripheral biliary radicals. In this case of a Klatskin tumor, one can see the lesion in the hilus of the liver. At that level, the portal vein can become involved. This liver typically shows multiple metastatic deposits which appear in yellow. A cast corrosion preparation of this liver revealed the supply of the metastasis, which was primarily from the hepatic arteries. That's why the yellow deposits now appear red. Small tumors of the liver may receive blood supply from the portal vein. And generally, like in lung cancer, the arteries are the ones responsible for the blood supply of the tumor. The larger the tumor, the greater the chance that the only source of blood supply is going to be the hepatic arteries. That's why the hepatic arteries are the ones that are embolized or chemotherapy injected in the artery and not in the portal vein. It would be a mistake to treat the tumor by infusing the portal vein, because generally it participates very little or not at all in the blood supply of tumors. Okay, these are two images of a study on a patient who had a carcinoid that metastasized to the liver. Note the hypervascular masses. Some have a central radiolucency. At first glance, they may even be confused with cavernous hemangiomas. Usually, you don't see multiple cavernous hemangioma, and when we see this pattern, we have to suspect the metastatic disease from a hypervascular primary tumor. This is another hypervascular metastasis, which was a solitary met from an islet cell tumor of the pancreas. And note the intense hypervascularity. Any type of islet cell tumor that metastasizes to the liver or other organs will carry its same blood supply tendency as the primary lesion. This is a patient who had colonic metastasis to the liver. To your left is the early arterial phase. To your right is the parenchymal phase. Note multiple hypervascular areas with intervening low-density areas. This is the usual pattern seen with the liver metastasis. This is an example of how the portographic examination of the liver, or the late CT examination following the opacification of the liver via the artery, when the portal vein opacifies and subsequently the liver opacifies, we may see better metastatic deposits or even primary tumors. The top left and right represent images from a selective celiac arteriogram. Note that we do not see hepatic arterial hypervascularity. In the parenchymal phase of the hepatic arteriogram, we may see, in this case, a very faint low-density area in the right lobe. However, when the portal vein was injected, in this case using the umbilical vein approach, in the early phase of the injection, we can see some separation of branches of the portal vein and relatively slow circulation. But in the parenchymal phase of the portographic injection, we see a large orange size solitary metastasis, which became more apparent in the injection of the portal vein than in the injection of the hepatic artery. That's why if we are to do a study of the liver with either CT or MR, we must get the delayed images to also record the effects of the contrast material injected as it goes into the liver via the portal vein. This patient had metastatic pancreatic carcinoma to the liver. And note in this cast where red was injected into the hepatic artery and blue in the vein, that the large metastatic deposits, only few exhibited arterial hypervascularity. This is a photograph of the same liver where we removed the red injected into the hepatic artery. And we can now see very large empty spaces. And these empty spaces corresponded to the metastatic deposits that only received minimal or no arterial hypervascularity. This is a patient with multiple liver metastasis. T1 was 1.5 seconds and T2 was 28 milliseconds. And note the multiple rounded lesions throughout the liver. Hypervascular hepatic masses may be the result of a vascular lesion, anywhere from capillary cavernous hemangiomas, etc. Hamartomas, regenerative liver parenchyma, which often is difficult to differentiate from hepatoma, usually shows hypervascularity. Neoplasias, primary neoplasias such as hepatomas, cholangiocarcinomas, and secondary deposits in the liver from particularly renal cell carcinoma, endocrine tumors, and melanoma tend to produce very hypervascular metastasis. The classic adenocarcinomas of the GI tract and pancreas generally exhibit hypovascular lesions of the liver. When describing the vascular changes and hemodynamics of diffuse and focal liver disease, we can understand the appearance of the liver when we perform CT examinations and MR studies. For example, transient hepatic attenuation in biphasic helical CT examination is characterized by enhancement on arterial phase and normal or nearly normal attenuation on portal phase. But we have shown that sometimes the enhancement does not occur in minimal arterial hypervascularity or no arterial hypervascularity cases. The mechanism and causes of the transient hepatic attenuation can be a portal vein obstruction, arterioportal shunting that may be seen in tumors, cirrhosis, trauma, interventional procedures, the Steele phenomenon by hypervascular tumors, focal inflammation such as liver abscesses, acute cholecystitis, and iatrogenic procedures, and finally from aberrant blood supply due to anatomic variations. But in summary, primary liver tumors and metastatic deposits receive exclusively or primarily their blood supply from the hepatic artery. The portal vein only contributes to the blood supply when the tumor is very small. When tumors are large, the portal vein may become obstructed and the obliteration of the portal vein and sometimes of the hepatic veins will produce low-density areas at the site of the tumor. And the arterial phase of a CT examination or of an MR study may or may not reveal the location of the tumor, but wait for the late images because these may be the most informative ones.